After meticulous planning and loads of preparation, the instruments are ready. The lights are focused. Introducing the Covington Surgery Center, a state-of-the-art outpatient surgical facility right in your own backyard. St. Tammany Parish Hospital, world-class healthcare close to home.
Hello and welcome to Healthy Living, brought to you by St. Tammany Parish Hospital. I'm your host, Christian Moises, and today we're going to be talking about imaging services, more commonly known as radiology, and those are the scans that patients may encounter anytime that they go to a hospital or see a physician. We're going to talk with Michelle Fell in a little bit. She's our manager of the Outpatient Rehab Facility at the hospital. But first, I'd like to introduce you to Les Bascle, manager of the hospital's Radiology Department, Inpatient Services, and Bryan Burleson, our manager of Radiology Services at our Paul M. Cordes Outpatient Pavilion. Thank you for joining us today.
Thank you.
Patients rely on us frequently to provide them to take a look at what's going on inside their body, stuff that they can't see. So we've asked you two to join us today to take a look at the different exams that they may undergo at our hospital. One of the common things a lot of people think, when they think of imaging services and radiology, they think of CT or MRIs. Bryan, do you want to talk a little bit about what the difference is between those?
Yeah. MRI and CT are actually very similar in some regards and very different in other regards. The ways that they're similar are the actual machine looks very similar. You know, they're a cylindrical machine that they look pretty similar. MRI is a little bit longer, of course. The way we acquire the images are completely different, though. MRI is basically using a magnet, a very strong magnet, usually up to 10 times the magnetic field of the Earth. It's that strong. So we use those magnets to actually acquire images of various parts of the body. One thing that's similar with the CT and MRI is the fact that the actual image itself is pretty similar in some regards. If you were a loaf of bread, we'll take a slice out and it looks like a slice image. It's an axial image. Both MRI and CT are able to acquire those images that way. So in that regards, they're similar, but like I said, they're acquired completely different. As far as CT, we're actually using radiation. It's ideally or realistically it's a fancy X-ray machine that we're able to manipulate the images to get various, whether it be axial images, coronal images, sagittal, however we would like it. But and like I said, in some regards they're very similar, and in others they're very different.
Yeah, and CT and MRIs are just two of the exams that patients may encounter. Les, I know that you were mentioning earlier that there are several others
right.
they may have.
Correct. When you come to the imaging services department, we can do ultrasonography, which a lot of people think of babies when they think of ultrasound, but ultrasounds, we use ultrasonic waves to get the images, and we do different exams. We do arteries, we'll do venous, we'll do abdomens, just to see multiple different things. Of course, we do the OB. We do nuclear medicine, which uses a nuclear isotope rather than a radiation source. Also, we have diagnostic x-rays, which is what most people get when they come into the emergency room. Also, some of the things we do is interventional radiology, which doctors place, drainages and that kind of stuff.
Bryan, you were talking a little bit, you get a lot of the same questions over and over again from
right.
patients, and that's not a bad thing. We would
right.
definitely want to make sure that they are prepared and are comfortable when they're getting these exams at the hospital. You want to kind of talk about some of those questions and,
Yeah.
and maybe give the public a little bit of some of those answers?
You know, some of the questions that we get every day, you know, in MRIs, like people are claustrophobic. Are they going to be able to do this exam? And you know, there's ways that we've kind of combated that problem in MRI. I spoke a little bit about field strength earlier. You know, how strong these magnets are, and how powerful they are. You know, we have an actual closed bore unit at the outpatient pavilion. But it's actually a short bore, so it's not quite so long. And the reason why we have that machine as compared to an open MRI is because it still has that field strength that they don't have on the open MRI machines. So you're kind of getting the best of both worlds. You're getting that image quality of a closed unit, but you're also getting the feel of an open MRI and the fact that it's a short bore and it's not quite as confining as others. It's also a big bore. It's
Right.
You know, the hole itself is actually flared on the ends, and it's a lot bigger than other scanners. So it's actually helped out a lot when it comes to claustrophobic patients at the outpatient pavilion.
I know noise is usually an issue too.
Noise is an issue in MRI too. It's like the way we combat that is, you know, we either give the patient earplugs, and a lot of times we'll give them headphones and let them listen to music, and that allows us to talk to them while the test is going on as well.
Right.
One of the common questions we get in CT a lot of times is the amount of radiation, and that's kind of a hot topic nowadays. The amount of radiation that you're getting in CT. You know, I think Dr. Oz spoke about it on one of his shows and things like that. We currently have 2 brand new CT scanners at the hospital, and I guess the manufacturers of these machines have really taken heed to the fact that people are concerned about that, and they've put a bunch of different things on these machines to kind of combat the radiation dose. You know, whether it be Care Bolus or Smart KV, Smart Mass, things like that. That's really brought the dose for CTs way down. It's also there's things that have sped up the process that allows us to take pictures of parts that we normally haven't been able to take in the past.
So at the end of the day, our exams and scans are safe.
Right,
We're
that's right. We're ACR accredited at St. Tammany. All of our CT, MRI machines are all ACR accredited. And what that means, even nuclear medicine, what that means is we've gone to the College of Radiology. They know there's a pretty extensive process that we have to use in order to become that gets that certification. And they say, okay, look, you know, your radiation dose is good. Your image quality is great. You know, this is a high quality place that you have.
And last, you know, we were talking a little bit. Y'all both kind of mentioned some examples of why you might get this exam or that exam.
Correct.
Can you give a rundown real quick, maybe, of why somebody would get a CT, why you would get an MRI, ultrasound, nuclear medicine, whatnot?
Okay, well, nuclear medicine, you look for different things. Like I said, we give you a radioactive isotope, which is safe. You won't feel anything or have any reactions to. Depending on what the doctor is looking for, is a tracer that will highlight an area. So like we're looking at your thyroid, they'll give you a tracer, it'll highlight your thyroid, and we're looking for nodules or cancer. So we do a lot of bone cancer as well, you know, looking for that. Ultrasound, we're looking, you know, ultrasound of your legs, looking for DVTs. Ultrasound of your abdomen, ruling out a tumor, looking for gallstones, looking for different abnormalities. Diagnostic plain films, we're looking for fractures, we're looking for lung cancer, pneumothoraxis. With CT, you know, you're looking for, like you said, you know, different abnormalities of the lungs, abdomens. MRI, you're looking for tear ligaments, torn muscles, you know, that kind of information.
And Brian, you mentioned, going back to CTs again, the hospital just did get, or has 2 new CT scanners. You know, we've been investing a lot with technology and really kind of trying to set the pace with that. You want to talk a little bit about what those 2 new machines actually do and the benefit of having them at the hospital?
Sure. Yeah, we have two brand new Siemens scanners at the hospital, which is they're wonderful machines. They really are. One is a 128 slice CT scanner, which basically means that every rotation it's got the capabilities of taking 128 images, 128 slices, which because it's such a big area, we're able to visualize a lot of things that we probably wouldn't be able to on another scanner. It makes it easier to visualize the heart, the cardiac CTAs, things like that. It also makes the timing a lot better, and it also reduces the dose quite significantly. So it's definitely a nice thing to have here at St. Tammany.
And the benefit of being able to get your exams, your imaging done at the hospital, and then have your treatment or rehab, which we'll talk about in a little bit, all under one roof is beneficial. Les, you were mentioning that earlier.
Right. You know, having all your imaging done at St. Tammany or its imaging centers it's all stored there for your doctor. They can come there in one-stop shop. They can treat you. They can see your images. And it's just there, and you know, a lot of times you have a radiologist will say they just read your CT and they recommend an ultrasound. But if you have all your studies at that one location, you might already have an ultrasound, so they can go back and look at your old study. You know, nowadays most places are using digital archiving, which we call PACS. And we do have that here at St. Tammany, and you know, we store your images electronically. We just installed a new software which allows the doctors to do some 3D imaging, so they can remove bone and see vessels better. It just gives them better technology and better studies.
We also have the Paul D. Cortez Outpatient Pavilion. We also have the Mandeville Diagnostic Center, and everything talks. You know, when a study is done, when a CAT scan is done at the Mandeville Diagnostic Center, the radiologist or the doctor or whoever is going to be able to see it at the hospital or at the Outpatient Pavilion or Mandeville. So it allows us to serve as a community in multiple locations as well.
All connected. So
all connected.
Always good to have it under one roof.
Right.
Well, Les and Bryan, I appreciate y'all being here.
Thank you for having us.
Yes, enjoyed it.
Got some great things going on. So when we return, we'll be talking with Michelle Fell, who is our outpatient rehab manager, and she's one of those places that will be able to use some of these scans, kind of where you can go to get fixed up after that.
They're the movers and the shakers. They're the ones who change our world. And they deserve places designed especially for them, built with kids' specific needs in mind. The latest technology in the caring hands of our dedicated pediatric specialists and primary care physicians, helping kids feel like kids. St. Tammany Parish Hospital, world-class health care for children close to home.
Welcome back to Healthy Living, brought to you by St. Tammany Parish Hospital. We just finished hearing about a whole bunch of different types of imaging services, scans and exams that you can receive at the hospital. And once you have those scans, one of the best places to go is our rehab department, which is why we have Michelle Fell, who's manager of our Outpatient Rehab Services, with us today. Talk a little bit about what they can do once you find those issues. Michelle, thanks for joining us today.
Thank you.
Tell me a little bit about what you do at the hospital, what your role is, and what outpatient rehab actually does.
Sure. I'm the manager of the outpatient rehab department. I'm a physical therapist, and we provide rehab services for the community, ranging in age from birth. We see babies all the way to our geriatric population. We treat orthopedic injuries, neurologic injuries. We have lymphedema specialists that specialize in lymphedema treatment. We have pediatric therapists, of course, that do work with the children. And there are 19 of us on staff. We have physical therapy, occupational therapy, and speech therapy.
Okay. Well, you know, talking with Les and Bryan just now, hearing about all the different types of things that they can do with their imaging, find those problems. Talking with outpatient rehab, how does a physical therapist, for example, use the results of what they're getting in assessing and treating orthopedic injuries, or really any kind of injuries that y'all deal with?
Sure. We correlate a lot of our clinical findings with what is found on a scan or an image. For example, an x-ray, of course, obviously if you've had a trauma, you fall down, you break something or injure something, you're going to generally have an x-ray pretty much immediately to rule out that there's not a serious fracture.
Right.
That has to be stabilized surgically. So we'll take those and correlate that to what we're seeing in the clinic. A lot of times we'll have a patient who comes in who had a non-displaced fracture, which is a fracture that doesn't necessarily require a surgery, but they'll be splinted and braced, and we'll have to determine from what their radiology scans show how bad that fracture is and how aggressive we can be with therapy. Some of the fractures they'll be displaced fractures, and they'll require surgical intervention to stabilize them, and then they'll come to see us afterwards, and usually the physician determines what the weight-bearing status of that person's going to be. Can they put their weight on it or not? So x-rays we use in that fashion. And then we use MRIs and CAT scans, which show more soft tissue disruption, to clinically coordinate what's going on that we see in, say, a stroke patient or a patient with a herniated disc in their low back.
Well, do you have to have a scan, though, an x-ray or an MRI before being treated by a physical therapist at outpatient rehab?
Not necessarily. Like I said, if it was a traumatic injury, there's generally an x-ray previous to us seeing them, prior to us seeing them, to make sure that there's not a break. And then we'll get them and start to treat them. Physical therapists are very well trained in systematic evaluation, and we determine what type of soft tissue injury may be occurring. We do special tests to determine that, and then we'll treat them according to what we find in our evaluation. If someone doesn't respond in, say, 4 to 6 weeks to our physical therapy treatments, then we will refer them back to the physician, where sometimes they'll do further diagnostic testing, like an MRI, to see if there's something else in there that didn't get caught by the x-ray or that we're not catching in therapy.
I'm just kind of curious, for how often, how long do people usually come to rehab? I know it's a case-by-case basis, but what would you say is an average amount?
An average? Well, it's kind of hard to determine that. So the flat answer is probably 4 to 8 weeks. Usually a month of treatment of some type. If you've got something that's giving you enough trouble, that you're having pain or dysfunction, it's going to take us a little while to get you better. If you've had a fracture, generally that fracture is not going to be healed for 8 weeks. So, we may be seeing you throughout that time, or we may not get you until after that 8 weeks. If somebody's had a surgery where you've been pinned, it's called an ORIF, an open reduction internal fixation. If that's done, you may not have therapy for 8 weeks until that's healed.
Right. And
then we get you to start getting you back on your feet, teaching you how to weight bear on it, that kind of thing. So it just depends.
Well, what are some precautions that PTs will take with patients, specifically when it comes to bone fractures?
If a patient has a fracture, of course the physician is going to determine usually what the weight-bearing status is for that patient, and also what type of range of motion they want done. If someone has had a really serious fracture with plating, pinning, then we are probably going to have them either non-weight bearing or toe touch weight bearing, which means you have to hop basically without your foot on the ground, or you can just put your toe down. So we use assistive devices such as crutches, walkers, canes, teach patients how to ambulate safely while protecting their fracture. So we do that. We also help with bracing, ordering specific braces for a patient, whether they need to be immobilized for a while, or maybe they're returning to sports and they need to have a brace that's going to support them in their athletic activities.
Right. Well, of course, the Bone and Joint Clinic at St. Tammany Parish Hospital just recently opened with Dr. Mark and Dr. Rock Hannes, the
Right.
Hannes brothers. So I'm sure you're working closely with them. What are the differences from the outpatient rehab side in treating joint replacements versus internal fixations?
A joint replacement, first of all, a total knee replacement is usually an elective surgery. The patient's had pain for quite a while and they're tired of living with it, and they've tried other means and other therapies, and they need something surgically done, so they have the replacement done. Those, as well as a traumatic hip fracture that requires a total hip replacement, those both, generally, we can progress them quicker. Usually in the hospital, the physical therapist will get the patient out of bed, either, not usually the day of, they try, but they don't really like us coming in there the day of, but the day after surgery, we'll get them up and they can fully weight bear on their extremity, on their leg,
Right.
pretty much immediately, unless the doctor feels like it's not real stable and needs to be, there need to be weight precautions. Whereas a traumatic fracture, we pin it, or the surgeon pins it, and they're not very stable. They need weeks to heal, and so we have to be very careful as far as how much weight they're able to put on it. And again, the physician usually determines that, and then they'll go back to their physician, and the physician will re-X-ray and say, okay, it's okay to start putting partial weight on it. So we'll start progressing them with their weight bearing. Also, if you've had a hip replacement, there are movement precautions that you have to be careful about, because you can move the joint in a certain way that will dislocate it, and that's not a good thing. You have to go
Right.
back to surgery. So we teach the patient how to function without, by avoiding, function and avoid all of those movements that can cause injury.
Well, what are some of the most common issues that outpatient rehab sees?
Common issues. We see so many different things. We see a lot of just knee and shoulder pain as the baby boomers start to age. We start to see more and more of that just from normal wear and tear. A lot of our patient population is not necessarily a car accident or a fall or some real traumatic thing. It's just over time they've had this shoulder that starts bothering them and they ignore it, and so eventually it gets bad enough where they go to the doctor and the doctor sends them to us.
Right.
So we see lots of shoulders and knees. We see spinal problems. 80% of America has low back pain at some point in their lives. So the spine keeps us in business. We also see stroke patients, head injury patients, children with developmental delays that aren't progressing as quickly as they should with their with their milestones, children with speech delays.
And tell me this, it's getting cold outside again. We have some cold weather still out there. A lot of people say cold and joints don't exactly work together. Do you see that a lot with your patients at this time of year?
Yeah, joint pain. I say that a lot of my patients can predict the weather more accurately than the weatherman can. A lot of times when the pressure changes, the patients all start complaining about their joints hurting, and if you've had an injury, when it gets really cold, you can feel that in your joints.
Right.
Definitely.
Rehab is one of those things that by the time that they get to you, I imagine they've already been fixed up, and now they just need that extra little push to get back to 100%. What are some of the questions that you get, some of the concerns from patients, and how do you kind of get them motivated to do what they need to do?
Usually by the time we get them, like you said, they've been through the worst of it. They've been in the hospital, or they've had some pretty bad pain, and they get sent to us to get them back on track. I think the main questions that patients have are, is it okay if I do this? They're afraid they're going to hurt themselves again. They're not really sure. Is it okay to bend my knee? And so we do a lot of education with the patients and teaching them, look, it's okay. It's going to hurt a little bit, but you're going to have to bend it. It's going to have to work. It's not going to work if you don't use it. Or just showing them exercises. A back pain patient is so afraid that they're going to get that excruciating pain again that they're afraid to move. So we have to teach them, these are the things you need to start doing. This is going to make you better. So that allays a lot of fear, I think. They just don't know what to do next, and we're the ones that kind of guide them.
Right. And we've talked a lot about the bone and joint issues and I guess skeletal issues that y'all see. You talked to them a little bit about developmental issues. Can we talk a little bit more about what y'all do on that realm?
Well, developmentally, are you speaking of like pediatrics development or
across
adults?
the board?
We do treat a lot of neurological issues, and I specialize in adult neurological treatment. So, getting back to the scans, a lot of times we use what the physicians find on a CAT scan of the brain to determine. To determine what we're going to expect clinically when we look at a patient. If a patient's had a stroke, for example, the CAT scan is going to show maybe the insult is in the cerebellum. Well, the cerebellum is the part of the brain that controls balance and coordination. So we're expecting in the clinic to see a patient that has balance issues, that feels very insecure, in space. And so that our treatment is going to be towards helping them to gain stability and feel more secure when they're functioning. Right. A patient who's had a stroke or a tumor in the motor cortex of the brain, which is the part of the brain that controls your motor function, then we're going to see on the opposite side of the body from the insult, we're going to see weakness, paralysis, and so we would use what we determine, what we see in the scan to determine, okay, this is what we're going to expect, and these are the things that we have to do to help that patient come back along. We take them through steps. I like to get my patients standing as soon as possible. They need to orient themselves to being upright again. It's very difficult. Sometimes it takes several of us, and we stand them at parallel bars, and hopefully they're able to progress, and we get them on walkers and things like that. But just trying to restore their as much function as we can. Right,
and you talk about the parallel bars, made me think, when I was over there the other day, it's kind of almost like a little jungle gym playground in there, and you mentioned pediatrics. Y'all do a lot of pediatric work also.
Yes.
I'm sure a lot of people are watching this right now wondering, is this just for patients from St. Tammany Parish Hospital, or is this anybody can be referred to the facility? No,
we take referrals from any physician in the area. Lots of pediatricians send their babies and their children to us. Some patients are diagnosed with a specific disability, such as cerebral palsy, Down syndrome. Others just, they classify them as developmentally delayed, and maybe they were premature at birth and they're just not quite reaching their milestones, such as maybe they're not sitting up yet and they're almost a year old. Well, they should be doing that by now. So the pediatrician will refer them to our department, and our pediatric therapist will work with the parents and the baby and teach them what kind of things they can do at home to encourage the child to meet those motor milestones.
Okay. Well, Michelle, did I miss anything about what y'all do? It's a whole bunch that goes on over there.
We do a whole lot. We do have lymphedema services, which is another specialty. I have 2 physical therapists who are certified in manual lymphatic drainage. And if a patient has had some type of an insult or a surgery that affects their lymph nodes, and some of the lymph nodes are removed or damaged, they can accumulate swelling in the arm or the leg, and that's called lymphedema. And it's treated by manual massage and drainage, and then wrapping the limb and ordering garments for the patient. So we do all of that in our clinic. We order custom garments or give them garments off the shelf that they can wear to control their swelling. That's a lifelong problem. It's not something that goes away. It's something that they have to manage for the rest of their lives. So we do a lot of education. as
Get
far
them
as
set
that
up and
goes.
ready to go.
Yep.
Okay. Well, we appreciate it. Glad you were
Thank
able to
you.
make it today.
Thanks.
And thank you for watching. We will see you next time.